Сегодняшний доклад посвящен мифам и псевдодиагнозам в сфере заболеваний щитовидной железы. И при подготовке доклада я набросала для себя тот список спорных вопросов в телеидологии, которые взяли на вооружение представители псевдомедицины, и, честно говоря, сама удивилась его длине, потому что речь идет всего лишь об одном узком направлении в эндокринологии. В чем же может быть причина такой популярности щитовидной железы? Давайте обратимся к симптомам гипотиоза. Полагаю, что любой врач терапевтической специальности подтвердит, что такие жалобы, как слабость, усталость, повышенная утомляемость, являются одними из самых частых на их приемах. Но прибавка в весе, отечность, сухость кожи, запоры – все это крайне распространенные состояния, которые могут встречаться при многочисленных заболеваниях. И лишь у небольшого процента пациентов с такими жалобами будет действительно выявлен гипотиреоз. Еще в начале 2000-х были опубликованы результаты популяционного исследования, проведенного в штате Колорадо, которое продемонстрировало, что отдельные симптомы гипотиреоза встречаются с одинаковой частотой как у людей с нормальной функцией щитовидной железы, так и у пациентов с гипотиреозом. При этом даже наличие 4 симптомов, характерных для гипотиреоза, не гарантирует его наличие. А более чем 35% лиц с подтвержденным диагнозом гипотиреоз не предъявляют вообще никаких жалоб. Соответственно, диагностировать гипотиреоз на основании одних лишь жалоб ни в коем случае нельзя. Поэтому представители псевдомедицины все же пытаются найти другие подтверждения наличия какого-либо заболевания щитовидной железы у пациентов с нормальным уровнем гормонов. Что же они для этого используют? Конечно же, в первую очередь в ход идут антитела к щитовидной железе. И давайте снова обратимся к статистике. По результатам популяционных исследований распространенность явного гипотиреоза в Соединенных Штатах и Европе не превышает 1%. Распространенность же субклинического гипотиреоза зависит от йодообеспеченности территории. В нашей стране не должна превышать 1–4%. При этом распространенность носительства антител к ТПО при нормальной функции щитовидной железы составляет целых 12%. Только на основании этих данных становится очевидным, почему исследование антител к щитовидной железе не позволяет подтвердить диагноз гипотиреоза. То же самое можно сказать о ультразвуковой картине, наиболее патогномоничным признаком аутоиммунного тиреидита. Основной причиной гипотиреоза является гипоэхогенность ткани щитовидной железы. Однако обратите внимание на перечень заболеваний и состояний, при которых также может наблюдаться этот ультразвуковой признак. У более чем 20% лиц с гипоэхогенной тканью щитовидной железы не выявляется даже повышенных антител к этому органу, не говоря уже о нарушении продукции гормонов. Пойдем дальше. Наверное, многие из вас наблюдали, как некоторым пациентам диагностируют гипотиреоз на основании ТТГ выше 2 или 2,5. А некоторые, может быть, даже приняли эту информацию как верную. Между тем, пик сомнений в корректности верхнего норматива для уровня ТТГ пришелся еще на конец прошлого столетия, когда в ходе популяционного исследования было получено вот такое представленное на слайде распределение уровня ТТГ среди здоровых жителей Соединенных Штатов Америки. Оказалось, что уровень ТТГ в интервале от 2,5 до 4 определяется только у 5% лиц с заболеваниями щитовидной, без заболеваний щитовидной железы и носительства антител. В связи с этим в 2003 году Национальная академия клинической биохимии США было высказано предположение, что лица с высоконормальным уровнем ТТГ могут находиться на ранней стадии гипотиреоза, поэтому им целесообразно переоценить уровень ТТГ через 3 недели или исследовать уровень антител к ТПО. Однако Распределение уровня ТТГ в других популяциях оказалось отличным в американской. Результаты исследований, проведенных в Германии и Дании, коррелировали с общепринятым референтным диапазоном ТТГ от 0,4 до 4, в связи с чем перед научным сообществом стал целый ряд достаточно серьезных вопросов. Что же это за вопросы? В первую очередь нужно было оценить, какова воспроизводимость лабораторной оценки уровня ТТГ у одного и того же человека. Какова стабильность ТТГ у него же во времени? Специфичен ли ТТГ в районе верхней границы 3-4 для заболеваний щитовидной железы? И что произойдет, если будет принято решение о сужении референсного интервала для ТТГ? Начнем с воспроизводимости. Погрешность анализа крови на ТТГ в лабораториях высокого качества считается нормальной, если составляет 10%. При этом вариабельность ТТГ у одного и того же человека во времени составляет 20%. В связи с этим та же самая Академия клинической биохимии США установила минимальные клинически значимые различия лабораторных измерений ТТГ в 0,7, что как минимум подтверждает отсутствие разницы в клинических подходах, например, при ТТГ 2,5 и 3,2 или 3,7 и 4,4. Рассмотрим наблюдение за 16 здоровыми мужчинами, которым ежемесячно измеряли уровень ТТГ в течение года. Была выявлена клинически значимая вариабельность ТТГ как в соответствии с предложенным референсным интервалом, так и с действующим. К примеру, у одного из участников исследования ТТГ колебался от 1,2 до 3,6, то есть от нормальных до повышенных значений в соответствии с предлагаемым референсом, а у другого от 1,8 до 5,4, то есть от нормальных до повышенных значений даже в соответствии с традиционным референсным интервалом. Еще более показательным является естественный суточный ритм секреции ТТГ. Посмотрите, как его уровень меняется у одного и того же человека в течение каких-то 6 часов. Если признать верхней границей нормы ТТГ в 2,5, то у многих людей утром будет диагностирован гипотиреоз, а днем уже нет. Перейдем к неспецифичности высоконормального уровня ТТГ. Посмотрите, как много причин повышения ТТГ вообще не связано с заболеванием щитовидной железы. Высоким ТТГ может быть из-за приема лекарственных препаратов, лабораторных интерференций, сопутствующих заболеваний, возраста, генетических мутаций и прочее. В контексте стабильности уровня ТТГ необходимо обсудить вероятность самостоятельной его нормализации, особенно при впервые выявленном повышении. Установлено, что в европейской популяции эта вероятность достигает 40-50%. Такой высокий процент, скорее всего, объясняется достаточно невысокой распространенностью аутоиммунного тиреидита и сохранением йододефицита, на фоне которого эпизоды повышенного потребления йода могут приводить к временному подъему ТТГ. Однако обратимость субклинического гипотиреоза высока не только в Европе. На слайде представлены результаты крупного исследования на эту тему, проведенного в Тегеране. Через 10 лет изначально повышенный уровень ТТГ оказался нормальным у 40% участников. При лечении субклинического гипотиреоза очень важно помнить, что эльтероксин имеет узкий терапевтический диапазон. По статистике, у 22% пациентов, получающих препарат, определяется сниженный ТТГ, то есть гетерогенный тиреотоксикоз. В то время как даже субклинический тиреотоксикоз, особенно в пожилом возрасте, и является доказанным фактором риска таких жизненно угрожающих состояний, как фибрилляция предсердия и остеопоротический перелом, а также ассоциирован с повышенным риском сердечно-сосудистой и общей смерти. Логично предположить, что диагностика гипотиреоза при более низких значениях КТГ приведет к еще большей распространенности тиреотоксикоза из-за назначения тироксина. Подведем итоги по этому вопросу. Проанализировав имеющиеся данные, научное сообщество еще 10 лет назад пришло к выводу, что сужение референсного интервала для ТТГ неоправданно и закрыло эту тему. Однако представители псевдомедицины продолжают популяризировать эти данные, представлять их как новаторские и, к сожалению, да, тем самым создавать сложности нам и нашим пациентам. Перейдем к еще одному популярному среди интегративных эндокринологов диагнозу, а именно к скрытому гипотиреозу или синдрому низкого Т3. Это тот самый синдром, который, по их мнению, наблюдается при плохом самочувствии у пациентов с нормальным уровнем ТТГ и свободным Т4. Придумал этот синдром еще в 1990 году доктор Вилсон, чья медицинская лицензия была аннулирована из-за подозрений на психическое нездоровье. По его мнению, в основе скрытого гипотиреоза лежит сниженная конверсия Т4 в Т3 на фоне стресса. Поэтому лечить его нужно назначением Т4 и Т3, несмотря на нормальный уровень ТТГ и нормальный уровень свободного Т4. Чтобы понять несостоятельность этой гипотезы, необходимо углубиться в метаболизм тиреоидных гормонов на периферии. Как известно, щитовидная железа, 90% гормонов, которые вырабатывает щитовидная железа, представлены тироксином, который на периферии конвертируется в 4 раза более активный трииодтиронин и неактивный реверсивный Т3. Конверсия происходит внутри клеток под воздействием ферментов D-ятиназ 1, 2 и 3 типа. Эти D-ятиназы по-разному распределены в различных тканях и активизируются при различных состояниях. Кроме того, для поступления тироксина внутрь клеток необходимы селен-зависимые транспортеры. Возможных причин снижения свободного Т3 в крови очень много, они представлены в таблице, однако далеко не все из них ассоциированы с симптомами гипотиреоза и купируются назначением трииодтиронина. В частности, при синдроме эутиреоидной патологии, связанном с тяжелыми нетиреоидными заболеваниями, снижение Т3 считается протективным явлением, а назначение трииодтиронина в такой ситуации может быть опасно. Только из перечисленных на предыдущем слайде состояний может быть эффективна терапия трииодтиронина. При полиморфизме D-ятиназа 2 типа, мутации в гене рецептора ТТГ и мутациях в генах селенопротеина. О том, насколько часто встречаются данные состояния, можно косвенно судить по результатам многочисленных клинических исследований. Результаты одного из них представлены на слайде. У пациентов с удаленной щитовидной железой, получающих тироксин, самочувствие никак не коррелировало с уровнем свободного Т3, а наличие усталости и слабости ассоциировалось лишь с безработным статусом и гиподинамией. Рассмотрим еще одну популярную псевдоэндокринологию тенденцию ориентироваться на уровень реверсивного Т3 и отношение свободного Т3 к реверсивному, которое якобы должно быть более национально. Ее представители утверждают, что при повышении реверсивного Т3 и нарушении снижения этого соотношения также развивается скрытый гипотиреоз. Обусловлено это, по их мнению, тем, что реверсивный Т3 конкурирует со свободным Т3 за связывание с стероидными рецепторами. Однако они совсем не учитывают, что связывание Т3 с рецепторами в 100 раз более сильное, чем связывание stronger as compared to reverse T3. That is why this hypothesis is absolutely groundless. And of course, clinically, we do not see any correlations between the level of reverse T3 and the symptoms of the thyroid gland disease and general conditions, anxiety and depression, as the results of almost 700 patients study showed who were on thyroxine treatment. Let's go to the treatment of hypothyroidism. Thyroxine does not always lead to the normalization of the conditions of the patient. In 5 to 10% of patients with hypothyroidism, despite the normal level of TSH, patients still have weakness, problems with memory, anxiety, etc. In this group of patients, there is a need of combination therapy T3 plus T4, despite the fact that most studies do not show subjective or objective advantages of combination therapy. In general, in the group of patients with polymorphism of dehydrogenase type 2, there was some improvement of the condition when this combination therapy was conducted. As a result of this, the European Thyroidology Association comes up with the following recommendations. Combination therapy, T4 plus T3, can be recommended as an experimental approach in compliant patients who get T4 when they have complaints despite the normalization of TSH, providing that other chronic or autoimmune diseases are excluded and can be the reason for such conditions. What conditions should be excluded before combination therapy is administered? You can see a long list of different conditions and diseases. Are they always taken into account? That's a major question. Just look at autoimmune diseases, which can be detected much more in different populations and can be the reasons for unspecific complaints in case of hypothyroidism as well. Let's compare recommendations with the relative treatment with combination therapy. In most cases, this therapy is administered without any thorough examination, without any attempts to identify other reasons. So if there is hypothyroidism, as doctors say, we can then resolve all the problems. T4, T3 can be administered in the ratio 4:1 or 5:1 instead of 15:1. The dose of the drugs is titrated until the symptoms are gone without taking into account lab indications. Low TSH is considered normal after such therapy. So what are the consequences of such treatment? They are shown on the slide. First of all, cardiovascular and bone complications of subclinical thyrotoxicosis, also immune and allergic reactions to drugs. Here you can see with age, well, atrial fibrillation chance can increase, well, the risk increases twofold as compared to euthyroidism. This slide shows the results of a large-scale prospective study showing an increase in general and cardiovascular mortality. Also, there are quite dramatic consequences of subclinical thyrotoxicosis. The odds ratio of compression fractures of the vertebrae is quite high and can be up to 3.5. That's it, dear colleagues. I'm pressed for time, although there are still a lot of controversial issues. If there are any questions, I'll be glad to take them. Thank you very much, Marina. And indeed, that was a very interesting subject, and I guess we can discuss it endlessly. I totally agree with you that symptoms in most cases are non-specific. Endocrinologists are well aware of the situation when we see patients with TSH, but there are no symptoms, and 5 to 6 with lots of complaints. Let's move on to the next presentation, myths and mistakes in the diagnosis and treatment of gestational diabetes mellitus. Lyudmila Ibragimova, an endocrinologist, the Senior Research Fellow of the National Center of Endocrinology. Please, the floor is yours. Lyudmila, turn on your mic, unmute yourself before you start. Can you hear me? Yes. Sorry for this technical problem. Good afternoon, distinguished colleagues. I am very grateful to the organizers to invite me to participate in this Congress, especially in this nice company of distinguished fellow doctors. As for my presentation, I'll be talking about the endocrine pathology during pregnancy, and in particular gestational diabetes mellitus. Women have hyperglycemia during pregnancy, and in more than 80% of cases, there are gestational diabetes mellitus. There are also the criteria for diagnosis of gestational diabetes mellitus. In 1964, O'Sullivan came with the first criteria for diagnosing gestational diabetes mellitus. And during 45 years, the criteria changed. Different international associations came up with different criteria for diagnosing gestational diabetes mellitus, but for 45 years, there was no one opinion on that. Lots of publications were published, even minor hypoglycemia during pregnancy, even with the low indicators for gestational diabetes mellitus, resulted in unfavorable outcome of pregnancy, both for the mother and for the fetus. In 2006, the results of the largest study were published in the New England Journal of Medicine. You can see more than 23,000 women were included in this study. The results have shown that unfavorable outcome of pregnancies were due to lower glucose levels than were accepted before, and this proof was quite significant. As a result of this study, in 2008, the International Conference on the Diagnosis and Classification of Gestational Diabetes Mellitus and IADPSG adopted new criteria for gestational diabetes mellitus. Many countries, including Russia, starting from 2010, adopted new criteria for diagnosing gestational diabetes mellitus based on the results of this study. It looks like all questions were resolved, and everything is written into documents adopted in many countries of the world, but the myths and mistakes in diagnosis of gestational diabetes mellitus are still there. What are the mistakes and myths that will occur in diagnosis and screening for gestational diabetes mellitus? One of the most widespread mistakes, and maybe it's a myth at the same time, is that many people think that screening for gestational diabetes mellitus should be done only when there are risk factors present. International documents and Russian clinical guidelines state that all pregnant women should be tested for gestational diabetes mellitus. We remember that any pregnancy is a risk factor for the development of gestational diabetes mellitus. These etiological changes which occur in pregnant women increase insulin resistance, and in the second trimester, 70% of women, or up to 70% of women, have such risks. And in this case, there is a high risk of the development of gestational diabetes mellitus. Pregnancy is the risk factor itself. All pregnant women must remember that if there is such a situation, screening is a must. The repeat testing for the glucose level to diagnose diabetes mellitus. Well, in order to make the diagnosis of gestational diabetes mellitus, well, there should be several tests done, and this refers to the entire gestational period. Well, if it's less than 7 millimole per liter, that's the limit. Well, HbA1 level for diagnosis of gestational diabetes mellitus. Since glycated hemoglobin is not used to diagnose diabetes mellitus, usually we use it for the first time to determine the manifested first-time diabetes mellitus. But to diagnose gestational diabetes mellitus, glycated hemoglobin is not a good marker, because glycemia is lower during pregnancy, and there was a shorter period of tolerance. And what should be the criteria for glycated hemoglobin? No one knows about that. That is why there is no such diagnostic criteria for gestational diabetes mellitus. 75 grams of glucose at OGTT is a high burden, thus leading to the development of diabetes. That's a myth. I cannot even call this a mistake. This myth is widespread among patients and among doctors. OGTT is a safe loading diagnostic test. Of course, there are contraindications for OGTT, such as diagnosed diabetes mellitus or early existing diabetes mellitus. Such things do occur when patients have this diagnosis of gestational diabetes mellitus at the early stage of pregnancy, and after week 24, this patient can be sent for OGTT. In this case, OGTT is not necessary. If the patient still has toxicosis, even at the later stage of pregnancy, OGTT should be postponed. Or when there are acute inflammatory or infectious diseases, or GI diseases, or when the patient is on bed rest. In this case, OGTT is postponed until the time when it can be done. As for 75 grams of glucose, well, I spent a lot of time on calculations, whether it's 75 grams, and in what particular sweets. It can be a piece of cake, such as this one, or 2 candies. On the right, each pregnant woman, if she has this kind of food, will get 75 grams of glucose. That is why the burden with 75 grams of glucose during OGTT is safe, and the test can be conducted by observing all the necessary rules. The next myth: can we replace 75 grams of glucose when you do OGTT with the sweet drink or other carb product? Well, usually the replacement of 75 grams of glucose, as many pseudo-doctors say, can be replaced by other products such as sugar or croissant with chocolate. That's the personal story of my friend who called me and said that I was sent to the nearby confectionery to buy a croissant with chocolate. I don't know why with chocolate, but we can recall lots of different stories of the replacement of 75 grams of glucose with something else, and the dilution of this glucose, if it is used in a small cup or glass with water. It's the picture of my friend. Again, the glucose is right at the bottom. The result of the test showed that the glucose level was very high. Fasting glucose level was very high, but 2 hours later, the glucose level became normal again. How can we interpret the results is not quite clear. The test must be conducted by observing all the necessary conditions in order to obtain reliable results and could get the conclusions whether the patient has gestational diabetes mellitus or not, and whether there is 75 grams of glucose is used or not. And again, patients say that you should drink this solution with 75 grams of glucose diluted in it. Well, you should not do this thing. Have mercy on our patients who already have a lot of difficulties. The OGTT conducted while patients are on glucocorticosteroids. This myth is also widespread. When the patient is on the 24th, 28th gestational week, she is hospitalized, she is on glucocorticosteroids, and when she is discharged, well, during the next 3 or 5 days of therapy, well, usually OGTT is conducted. Patients come to us with these results when OGTT is conducted on the day of discharge, but this should be done 3 days after glucocorticosteroids are canceled, not when the patient is on these drugs, because these drugs lead to an elevated level of glucose. That's quite natural. We should not forget it. And in principle, for diagnosis of carb exchange, OGTT should not be conducted when the patient is on drugs that may have an impact on glycemia. So there are specific rules for OGTT. Well, the administration of OGTT in case there is early glycemia. That's what I mentioned before. If gestational diabetes mellitus was already established and there was the problem with carb exchange, OGTT should not be conducted. We do OGTT just to diagnose gestational diabetes mellitus. If diabetes is already diagnosed, there is no need of OGTT. Sometimes patients come to me and ask me why I was given OGTT if I already have gestational diabetes mellitus. To determine the venous plasma glucose during OGTT while fasting and 2 hours after. Well, I gave you this example with the results of OGTT. A patient came to see me, and well, you can see fasting glucose, and 2 hours after the burden, the patient went and had another OGTT, and you can see the results. An hour later, after the burden with glucose, well, she can be diagnosed with gestational diabetes mellitus. So the patient had gestational diabetes mellitus missed, and the consequences could be quite significant. During OGTT, we determine 3 levels of glucose, and 1 out of 3 is quite necessary to diagnose diabetes mellitus. You can see also the diagnosis of diabetes mellitus as a result of the glucose test in 3 points. In point 2, after the burden with glucose, we can see the figure is higher than 11.1 millimole per liter. These are the criteria of the manifested diabetes mellitus diagnosis, but only after 2 hours with the glucose burden, regardless of the intake of food. The criteria for diagnosis of manifested diabetes mellitus during pregnancy are the same as without pregnancy. Fasting glucose 7.5 millimoles per liter in 2 hours after the burden with glucose 11.1 millimole per liter and higher. In this case, we can say that the patient has manifested diabetes mellitus. The use of specific devices such as blood glucose meter or glucose monitor to determine diabetes mellitus. We do not use blood glucose monitors, and I know that sometimes blood was taken from the vein, but it was put on the test strip of the blood glucose meter. Only from venous plasma and only in a lab such tests can be done. After 28 weeks of pregnancy, OGTT must not be conducted. The optimal timing for OGTT is 28 weeks. However, it can be done up to 32nd day of pregnancy. Why up to 32nd week on pregnancy? We go back to the HAPO study when OGTT was done from 24 to 32nd week of pregnancy, and the diagnostic criteria adopted as a result of the HAPO study were developed for those periods of pregnancy. If for some reason the 24-32 week of pregnancy period was not the period when the test was conducted, it can be done up to the 32nd week of pregnancy. Now let's move to treatment of diabetes mellitus. There are also a lot of myths and mistakes. Control of glycemia using flash monitoring. We encounter this quite often. Our patients would like to reduce the number of punctures. For them, it's not quite a normal story, like 4 measurements per day is quite burdensome. And also, you can use flash monitoring to measure glucose, but can it replace the blood glucose meter? No, only as an additional method. When we can use flash monitoring during pregnancy, glycemia is determined using blood glucose meter calibrated according to plasma. It should be approved by the regulatory organs. And during pregnancy, patients with gestational diabetes mellitus glucose control is done 4 times a day, fasting and 1 hour after the intake of food, after breakfast, lunch, and dinner. Exclusion or sharp limitation of the use of carbs in food. That's a mistake made by our patients and also by doctors who recommend this. If carbs increase the glucose level, of course, carbs should be excluded. But we must remember that carbs are the main source of energy in organism, and during pregnancy, well, there is a lot of energy waste. And of course, energy is needed. In this case, pregnant women need 175 grams of carbs per day, or at least 40% from the calculated daily calorie intake. And the last intake food interval between the dinner and breakfast should be at least 10 hours. Well, of course, we exclude the poorly absorbed carbs, but in general, of course, carbs should be in the food ration. Well, women who suffer from obesity and, of course, the recommendation to have the fasting day is one of the myths here. Women with insulin therapy in case of ketonuria is another mistake made by our colleagues. Also, ketones occur as a result of limitations of the carb use or due to the long interval, especially night interval between dinner and breakfast next day. When it's more than 10 hours, false positive results are quite possible as far as ketonuria is concerned due to the intake of polyvitamins such as containing riboflavin, ascorbic acid, well, also the urinary tract infections. In this case, ketones levels should be determined in the lab. Also, you can see that as for insulin therapy, it is recommended when there is when it's impossible to achieve targeted indicators. Analyzing the food diaries, we can identify the reasons for higher glycemia postprandially or while fasting, and depending on the food ratio, we can say that in 80% of cases, targeted indications of glycemia are possible to achieve due to the modification of the lifestyle and observing specific dietary and increased physical activity. Another mistake when insulin therapy is administered is when we start with low doses. The calculation of doses of insulin should be adequate. The initial dose should be adequate as well. This slide shows that we reconsidered clinical recommendations on gestational diabetes mellitus. Here you can see the starting doses, and they are quite adequate. Well, not less than 6 insulins, prolonged insulin, 8 to 10 international units. Finally, hospitalization to administer insulin therapy. There is no need of it. Hospitalization is a must only when there are obstetric complications. In conclusion, I would like to say that any pregnancy is a risk factor for the development of gestational diabetes mellitus. The diagnosis is a must for all pregnant women. OGTT is a safe diagnostic test during pregnancy. We should do 3 tests. The need to observe all the stages of OGTT is a must, and all pregnant women should have a self-controlled diary with the indications related to physical activity, food intake, and other factors involved. Thank you very much. That's all there is to it. Thank you, Ludmila. That was a very interesting presentation and very relevant. All these myths and mistakes is our pain, the pain of endocrinologists. The more often we discuss them at our congresses, the less there will be such myths and mistakes. I'd like to thank all our experts. Let's move to the next presentation, Myths and Controversial Issues in the Treatment of Osteoporosis. Svetlana Mirnaya, a member of the Russian Association of Endocrinologists, of the Russian Association of Osteoporosis, and the European Society of Endocrinologists, will make a presentation on this subject. Svetlana, please, the floor is yours. Thank you, Olga, dear colleagues. Thank you for this opportunity to speak at this Congress, and I would like to raise this issue, myths and controversial issues in the treatment of osteoporosis. Osteoporosis is a chronic disease. It's a metabolism disease. Well, the microarchitectonics of bone tissue is violated, and it can lead to fractures. Well, osteoporosis is the disease of elderly women. That's the first myth. Well, usually we imagine an 80-year-old woman with a walking stick, but that's not so. Osteoporosis develops at an early age, even before menopause in women, and right after 50 years in men. Osteoporosis, well, can be diagnosed at 50 and even earlier. Another myth is that osteoporosis occurs only in women, and we underestimate the spread of osteoporosis among men, and that's why men do not get proper treatment if they have even a high risk of fractures. If we look at the modern classification of osteoporosis, primary osteoporosis, well, 95% of cases of osteoporosis is in women in menopause, but there are also juvenile osteoporosis. There is also osteoporosis in men under 50. Another myth is that trauma specialists can treat osteoporosis because it can lead to fractures. But that's a myth. In fact, osteoporosis should be treated before the fracture occurs, and only an endocrinologist, a rheumatologist, or a therapist can treat such a patient. Well, right now, as an endocrinologist, I am delivering this lecture why endocrinologists should be involved. Well, there is secondary osteoporosis, and there are specific reasons which lead to low bone density, and there may be endocrine diseases such as hypothyroidism, well, thyrotoxicosis, diabetes mellitus, well, hypothyroidism. Lots of diseases can lead to the development of secondary osteoporosis. Our task as endocrinologists is to make a thorough examination and to exclude such conditions. Also, maybe some other conditions such as rheumatic diseases, malabsorption, COPD, etc. So if we look at the modern classification and include secondary osteoporosis with all these reasons, well, in this case, there will be mixed osteoporosis when women in menopause have other risk factors such as low calcium intake or concomitant diseases. And unfortunately, many colleagues have the idea that we do not have the densitometer, and that means no diagnosis. Well, no diagnosis in this case, that's a dangerous myth because there is a special instrument. It is free. It's the algorithm FRAX, Fracture Risk Assessment Tool, to assess the risk of fracture. And You can just download it from the internet, and this FRAX algorithm was approved by the World Health Organization, and you can assess the probability of fracture. We can make a diagnosis and start treatment. This screening is recommended for all women in post-menopausal period and for men after 50. So the use of FRAX can diagnose osteoporosis, we can start early treatment, and we can interpret the data properly. Thus, FRAX is a free method of diagnosis of osteoporosis. The next myth is the diagnosis of osteoporosis can be made on the basis of blood test. And naturally, as a result of it, we can administer different bone metabolism markers. That's a myth. The diagnosis can be based on FRAX data or when fracture occurs, but not on the basis of blood test. Nevertheless, we can say that patients who have such a diagnosis, well, we can use the blood test to confirm the effectiveness of treatment, but that's it. Myths from the patients. Well, I eat such a product as farmer cheese or cottage cheese, and that means it will protect me from osteoporosis. Well, but I should say that in this case, I will have enough calcium. In case of osteoporosis, the requirement for calcium is very high. In women in menopause or over 50, it's from 1,000 to 1,500 milligrams. Well, elderly people absorb less than 30% of calcium, but there is a special calcium calculator. It's in English, but you can use the browser translator to calculate the calcium level. Well, another myth is I'm going to take calcium supplements, and in this case, I won't have osteoporosis. That's also a myth. The bone does not consist of calcium per se. What else do we need here?
We remember that the main components of the bone, mineral components, and we need a lot of calcium molecular. We need potassium, bore, zinc, selenium, and 1/4 of the bone is organic matrix, collagenic and non-collagenic proteins. When we discuss food, we talk not only about food, we talk about proteins and other microelements. And of course, we talk about vitamin D. The very common myth is that I don't need to take vitamin D because it's spring or summer. I'm getting vitamin D from sun. I don't need your tablets. If we check the map, we'll see that all the Russian Federation is upper than 42nd parallel. And that means that from November to February, we just don't get enough of ultraviolet rays. And with age, skin is worsening, developing vitamin D. And if we ask dermatologists, they would say that it is not good to stay in the open sun and we need to cover it with SPF protection. So that means that we do not always have enough of vitamin D. In food, in Russia, we do not have food enriched with vitamin D. Probably in neighboring countries, the situation is different, but that's what we have in Russia. As a result, I have only a few cases when we have normal level of vitamin D without taking vitamin D. But if we talk about osteoporosis, we definitely need to take vitamin D as drugs or biologically active additives. The other myth is that the patient with osteoporosis is a very fragile person and you need to restrict your physical activities. Ideally, put yourself on soft cushions and do not meet. But mechanical activities stimulate anabolic processes in bone tissues and decrease bone resorption. And there is meta-analysis data that demonstrate that physical activities decrease the frequency of fractures. If there is already a fracture, we can talk about special gymnastics. If there are patients with higher risk of fractures, we try to avoid some excess loads, but certain trainings we still need. We need to decrease the risk of falls. We need to improve coordination. And even in patients with osteoporotic fractures in history, we still need to control these physical activities. The next myth is that osteoporosis is not treated kind. I ate cottage cheese, I stayed at sun, but nothing worked. We have to agree here from the very beginning. What is the treatment for osteoporosis? Where I started, osteoporosis is a chronic disease such as hypertension or atherosclerosis. When we start these drugs, we do not stop them in the patient. Here we have the same situation. We have a chronic disease that should be treated for a long term. And it is very important to talk about the purpose of the treatment. And the purpose is avoiding of fractures. And the resultfulness of the treatment is the density of the bone. It can be stabilization and even increase of the bone density. Nevertheless, our task is decrease of fracture risk. And actually, to prevent and to treat osteoporosis, we have a number of drugs. They have different mechanisms, different particularities. They can be efficient. They are accessible in the Russian Federation. There are different prices, but there are those that are included into the list of vital and essential drugs. It's important that we want to help the patient, and then we will be able to help patient. But no, absolutely no drugs will work if the patient does not have the calcium, vitamin D, balancing of his or her physical activities. So if we talk we can talk that we need to prescribe bisphosphonates, the drugs that decrease resorption, and we have terapevtin. All the groups of drugs are different. The most well-studied and long-term prescribed group of drug, bisphosphonates. It is the golden standard for treatment of osteoporosis. They are inbuilt in the bone tissue and they do not allow the signal to go to osteoblast. The resorption of bone marrow, of bone tissue decreases. And we see that they are registered for different types of osteoporosis. They can be in tablets that are used once per week and parenteral, even intravenous. It can be used once per year. It is very comfortable, even if the patient buys it itself. The price is quite adequate, and you can always find some good possibility. Denosumab is also anti-resorption activity drug. It does not inbuilt into the bone tissue, and it decreases resorption. Its particularity is that it does not have effect. It doesn't have a back effect, so there are special particularities when it is prescribed. It demonstrated its efficiency. If we talk about the fracture treatment, it is injected subcutaneously once per 6 months. It can be used in men and women. And if the patients get inhibitor aromatase treatment in men with prostate cancer and in women with breast cancer, it can be used in these patients. It is particularly recommended if we see most of loss in cortex bone, if we see that in the femoral neck, there is decrease and depletion of the bone, we still can prescribe it. As for EGFR, it can be prescribed with any EGFR. The mechanism is the same. And the third group of the drugs, teriparatide, the only available drug for anabolic therapy of osteoporosis. It is a gene-engineered fragment of paratahormone molecule. It is also registered for all main indications, and it is particularly indicated for men with osteoporosis, with their bone border fractures, and to decrease the spine pains. Its disadvantage is that it is subcutaneous subcutaneous injection, and not all patients can get it due to certain disabilities. You see that there are lots of drugs, and there is also some idea that we need to start with bisphosphonate. We know them better, they are well studied, and if they do not help, we will add something. But it's important to evaluate the risk, initial risk, and to start with most efficient treatment. If there is a patient with multiple compression fractures, the patient has significant risk of secondary fractures. We start with teriparatide, then we can shift to denosumab. It can be taken from 5 to 10 years, and if we want to increase the effect of denosumab, then we prescribe bisphosphonate. They do not allow to develop the back effect after discontinuation, and if we decrease the risk, then with bisphosphonate we can consider the medication holidays. We can stop treatment for certain period of time, but still we need to control the whole picture. And the last myth that is regarding the complications. There is some myth because there can be complications such as joint necrosis and atypic fractures. I would love to stress here that the bisphosphonate therapy and denosumab can lead to such complications. And what is very important here is the regimen that we use here. These drugs are used for oncological patients in different regimen, in other dosages, and the patients read the guides for the drug, and all the side effects are described. But the dosages are different. If we talk about osteoporosis, if we talk about bisphosphonate denosumab, the frequency of osteonecrosis of lower jaw is 0.001%. Yes, it's higher than in general population, but to the patient, we need to explain their level of risk. If we talk about oncological patients, of course, the risk is high, and there are certain risk factors. It is the longitude of therapy, glucocorticoid usage, when there is therapy with inhibitors of angiogenesis, smoking, you can discuss this with the patient, and comorbidities such as diabetes, oncological diseases. What can we do from our side to prevent this complication? We always evaluate benefits and risks. We send the patient to the general evaluation to the dentist, and the dentist always have to perform the sedation. And if there is a need to extract or implant the tooth, we need to have a good dentist who understands the particularities of osteoporosis treatment. And thus we decrease these risks. Yes, it must be discussed with the patient, and we can influence these issues. To conclude, I would love to say that osteoporosis does not hurt, but there is decrease of quality and quantity characteristics of bone, and there is risk of fracture. Even with a minimal load, osteoporosis can be detected and treated before fractures, and osteoporosis can be treated. Thank you so much, Svetlana. Very informative, very good lecture for support of osteoporosis. And now myths about adrenal diseases. And Alexander Tsibirke will present it. He is the physician from Almazov Center from St. Petersburg. Thank you so much. Well, I think we already discussed special questions, and I hope that I will speak about interesting issues, and we will talk about myths of the diseases on the adrenal gland. Before we go to the myths, as therapists are listening to us, I would love first to talk about the real pathology of adrenal glands. Then I will talk about myths, how they appear. We've already discussed predispositions for pseudo-diagnostics, and then we will use particular examples, and then I will not hesitate to go to the main topic where my colleagues have already set very high level. We will not talk about embryology, about mesothelial cells. We have to say that adrenal glands exist. There is cortex with steroid hormones, catecholamines, and there are certain pathologies. And in any pathology, there are situations when there is excession of hormones and a decrease of hormones. There can be autoimmune destruction of adrenal glands, Addison disease, Waterhouse-Frederick's decrease, or some surgery. The idea that if there is no adrenal gland, then there would be lack of hormones, but there can be hyperfunction of adrenal gland hormones. There can be excessive rate of these hormones. These are particular nosologies with particular substrates. So a few words. I think that lots of my colleagues have heard about primarily hyperaldosteronism, and arterial hypertension can be a problem here. Physically, these are typical people who came to the polyclinic. According to the different guidelines, these are 5 to 10% of patients with hypertension, and some experts do not agree with this number. We can, of course, discuss it with my colleagues. In my experience, I work in big cardiology clinic, and sometimes pretty often they call me to exclude hyperaldosteronism the patient, in my mind, there are patients, 3% of the patient, 2%, and this is the different work in the big center that covers 6.5 million people, and only few of them, not 10%. So I think that 10% is too much a figure, and there is very quite screening hypertension with hyperkalemia, resistant hypertension. There are very clear criteria and very clear screening algorithm and training, and there are very clear bordering meanings, and after that meanings, after that figures, we know what to do. If it is primarily detected aldosteronism, there would be low renin. If we verify primary hyperaldosteronism, we will discuss specific pharmacological therapy. If we see that there is excessive hormone situation, this is a particular pathology. The other particular pathology is hypercorticism, but I think probably you've seen exogenic hypercorticism. When we see prenalization, use now Cushing serotype. Endogenic is not seen that often. In my practice, I see it more often. But we see also very clear indication how to evaluate patient for hypercorticism. It can be particular phenotype with diabetes, hypertension, osteoporosis, and so on. There are quite clear indications and clear diagnostic procedure. It is cortisol in 24 hours urine, cortisol, and cortisol during night. And we see very straightforward criteria how to interpret this result. It can be adrenalectomy or adenomectomy or blockades of steroidogenesis. It is very particular disease. Pheochromocytoma probably was seen only in the books and in the medical series, but we do see it. And we talk here not about the widespreadness, but about the morbidity. And there are certain screening criteria: resistant hypertension, paroxysm. And again, here we have quite clear tests. We have to see metanephrine in blood or in urine, and usually the treatment would be surgical. The different situation when the adrenal gland is not working well, we will talk about adrenal gland failure. And we see low cortisol here. If we see hypothesis pathology, we don't see that KTG is developed and cortisol level is decreased. I often see this picture, but I work in neurosurgical departments. So if we see adrenal gland failure, the symptoms are non-specific. There is fatigue, there is if we see the deficit of minerals and glucocorticosteroid, the symptoms are specific. This is degrees of body weight, orthostatic changes. There are certain criteria, and we talk about probability. And again, there is very quite clear algorithm to confirm the diagnosis. So in the primary, cortisol is very low, and if we see some gray zones, we see some functional possibilities. We check the system and probably will see not so obvious issues. There is the test with insulin hypoglycemia. If cortisol is too high, we see that if the basal meaning of cortisol was not very low, it goes up. And so one more time, the real pathology of adrenal gland is very particular pathological substract, and there's a problem where there is particular algorithm of diagnostic, and either specific drugs are prescribed, and we can hope for some replicable result. In real pathology, it does not work always. There are some tumors, we always can talk about syndrome, but syndrome is kind of an abstraction, and there can be some symptoms that unites it. It can be a syndrome of polycystic ovaries or irritated bowel syndrome. There are certain criteria when we talk about some syndrome and further work. Syndromes exist, definitely. But this also exists. There are a number of alternative syndromes. Alternatives. Sorry, I was quite emotional right now. Why? Why does it happen? In the first presentation, we've heard about predisposition for pseudo-diagnosis. 70% of ambulance. These are healthy people, and they come with non-specific, and they are wonder why they are not happy. Because it always can, they want to have some very simple result. I will take Chrome, and this is a very good soil for alternative specialists, for alternative experts, because to sell some idea, you don't need to know more than this person. And let's not lie to anybody. If we talk about adrenal glands pathologists and talking about this steroidogenesis, if we talk the thymus, we've already discussed this, esoterics, we need to think about some designers norms. We really have to create something, but if we talk about steroidogenesis, there are a lot of hormones and their precursors, and there is a request to interpret the deviation in the tests. They do not have quite a big number of words such as TTG, hypoxia, and there are some words about adrenal glands. And the problem is that absolutely any hormone and any precursor can be an explanation for any symptom. And if we talk about certain tests, the more analysis, the more tests the patient pass, there would be something that is no in the reference, and it can be sold to the patient. And if we talk about adrenal glands pathologists, there are a lot of possibilities for that. There are lots of analysis, lots of precursors. We can find it in blood, in saliva, in any person. We can find absolutely anything. And if you want to tackle medicine, we have to remember that not all the numbers on paper have clinical significance. And most of these steroid profiles are commercial thing. And the level of aldosterone can be seen in some pupil parameters. And That's why we have here this story about tired adrenal glands and what you see in your practice. But let's even presume that tired adrenal glands can exist. There is a study the spoiler is here in the name of it. Adrenal fatigue does not exist. The authors take 3,000 papers and half, and they collected some where there is some real data, where there is some link between the state of the adrenal gland and patient's feelings. It's a very complicated chart. The authors analyzed all the possible tests. They analyzed the level of cortisol, the level of KTG and other levels, and they evaluated if there was some link between the adrenal gland functionality and the state of the patient. Then mostly there was no difference. In some patients, something was lower, something was higher, but it is absolutely the same as we see in the real practice. So the authors concluded that the result of the previous studies were contradictory, using all the methods for assessing fatigue and the HPA axis, and the most appropriate methods to assess the HPA axis were not used to evaluate fatigue. Therefore, evaluate the adrenal gland fatigue requires further investigation by those who claim for its existence. And they also stress that analysis for cortisol, they should not be prescribed if you do not think that there is some problem. Sometimes the glucocorticosteroids are prescribed. The best therapy with glucocorticosteroids is the therapy that was not prescribed, and Endocrine Society say that there is no test to detect adrenal gland fatigue, and it is impossible to repeat it and to prescribe it. Okay, let's say probably there was no link because people can be tired. What if we just prescribe glucocorticosteroids? There are such works, and this is one of the biggest studies. These are patients with fatigue. They were getting hydrocortisone and fluorocortisone. Endocrinologists can see that the dosage is not high. They took the small dosages because in the previous work, this dosage would improve the state of the patient. In the dosage 5, hydrocortisone does not suppress the state of there can be some tiredness, some depression, and it's quite unexpected, right? Globally, that did not work. And mainly in these patients, we have to study alternative situation. Globally, it can be depression, COPD, and so on. And that depends on the syndrome of chronic fatigue. Some alternative experts, they can prescribe 250 biologically active additives. And the problem is, this is a very interesting work. The authors ordered 12 most popular biologically active additives, and in each of them there were T3 drugs, and there were steroid hormones, so-called natural biological additives. This is the patient with adrenal failure, and she has Cushing, you see, diabetes, and she rejected hydrocortisone, and she said that she does not take anything, and for a few months she already takes biologically active additives for the and she had increased dexamethasone, though it is written that the chondroitin, glucosamine, and so on, there was dexamethasone. In medicine, prima non nocere, so we have to remember that it is not always prospective possibility whether these are myths or not, but you can see it in your therapeutical practice. The first, if you think that we need to exclude cortisol, don't check basal cortisol level in the morning. You cannot interpret it. So if you think that cortisol is excessive, either it is a night saliva or probe with 1 milliliter of dexamethasone. Though usually cortisol is not low. A second point, if you see some strange always exclude that the patient where the cortisol was leveled and asked few times, does she take anything? And then they said, yes, I have atopic dermatitis and I use hormonal ointment. Don't forget, the patient does not always realize what he takes. I have a picture how patient gets Cushing syndrome with the last point. This is the reason for the separate lecture. The patient can have some deviation androgens, and sometimes there are huge dosage of dexamethasone are prescribed. This is wrong in most cases. If you see something in your practice and you don't want to deal with it, ask to listen to the second opinion. This is not right. So to conclude my presentation, there are real pathologies of adrenal glands. I hope you remembered about it. Myths appear because there is a demand from the patient. They are not satisfied with what they hear, combined with lack of knowledge and commercial things that we can see. Adrenal gland fatigue does not exist. It's some abstract thing that is based on magic thinking of our patients and unfortunately our colleagues, and a little bit of wisdom. I tried to provide you with it. I hope our adrenal glands are not fatigued. Thank you so much, Alexandra. Very interesting. Talking about biological additives, it's a very big problem. We still have 10 minutes for all the questions. I will read them very quickly and you will answer. Marina Alexandrovna, the questions to you. The lady plans pregnancy. She has autoimmune thyroiditis. TTG at the moment 3.9. Should we prescribe hormones as she plans and during the pregnancy? Well, when the pregnancy is planned, TTG 3.9 is normal. Thyroxine is not needed here. When pregnancy appears, TTG stays at the same level, then thyroxine must be prescribed according to all the guidelines. and the TTG was normal, and we have to deal with it, notwithstanding the level of TTG and thyroxine prescription. Thank you so much. The next question, autoimmune thyroidite. Levothyroxine TTG is normal, but sweating does not stop. What's the reason, dear colleagues? Does anybody want to answer this question? I can answer that. Unfortunately, the data is not enough. We cannot explain what's the sweating. What do you think, Marina Alexandrovna? Yes, this is a classical myth, very classical myth. I have not talked about it. You want to think that the thyroid gland is responsible for all the problems. When TTG is normal, we do not connect anything with thyroid gland. Yes, there are a few more questions about thyroid gland, how to prevent development of hypothyreosis, and if it's possible to prevent. There is no proved ways to prevent hypothyroidism. Statistically, there are 3 to 5% per year, and healthy lifestyle, good meal, stress protection can influence these risks. I always tell my patients that they have to love themselves, be careful about themselves, not to overload themselves, and so on. Levothyroxine, 225 micrograms, TTG, 91.48, T4, 935 in becamoles. What is the tactics? Well, as far as I understand, it is not compensated hypothyreosis, though thyroxine level is high. Probably it is not correct. Taken probably the drug is combined with some drugs that influence its absorption. Probably the patient does not take it regularly. Sometimes, very rarely, it is malabsorption syndrome. As the result of the studies, it is a very, very rare situation. It can be sometimes explained with some GI problems such as celiac. We have to exclude it all. Sometimes the conversation with the patient allows to detect this. Lyudmila Ibragimovna, the next question is to you. Can we set the diagnosis of gestational diabetes on the early stage of pregnancy and gestation age 5 to 6 weeks? This is a good question. We set the diagnosis from 5th, 6th weeks. This is always plus or minus a week. I would always check what is the level of glucose. If it is 507, we can check it again in a week. If it is 5.6, 5.4, I don't think it will change significantly. And the changes in the organism after 6th and 7th week, which say that the serious pregnancy and leukemic indicators change significantly. If it is significantly higher than 5, I would set this diagnosis. But if it's a middle, some bordering indicator, I would not probably. The next question, what are the level of glucose that are after the 32nd week of pregnancy. Fasting glucose, it must be 5.1. If, for example, in glycemic profile after the lady was hospitalized, and yes, gestational diabetes can develop on the later stage when it's near 30th and 32nd week, but the criteria for diagnostics after glucose load, we do not have this criteria. We have only criteria for fasting glucose, 5.1. If a baby is big, if the fetus is big, we can think about hyperglycemia. And we control glucose the same as when it's gestational diabetes. We can control glycemia or blind monitoring, but I don't think they use it anywhere. And detect it. And exclude other factors of a big fetus, not always the big fetus hyperglycemia. We have to consider the proportions. We have to understand where we see the signs of hyperglycemia. But for diagnostic after the 32nd week, we don't see it. We have to analyze all the factors together, and even fasting glucose will demonstrate it to us. Glucometer indicators will also shoot, and we will recommend the diet for the patient. And we said that we cannot exclude the disturbance of carbon exchange, and we do not have any good, reliable tools for diagnostic. Should we perform glucose tolerant test if the pregnant is taking all the pregnancy, the drugs that increase the glucose blood, and how to diagnose the gestational diabetes? We do not perform glucose tolerant test when we talk about short-term glucocorticosteroids. If the patient takes the drugs during the whole pregnancy, we still perform the test, because if there is issue with gestational diabetes, there would be increase of glycemia, and it would be chronic glycemia during the whole pregnancy, and there would be complication of the pregnancy, and that's why we need to detect it. Yes, we perform this test in this particular case. What are the test straps you recommend to evaluate ketone bodies in urine? Absolutely any. It is not important. Svetlana, the next question is to you. What is your point of view if you talk about prescription of vitamin D? If you talk about vitamin D in the osteoporosis, if there is primary hyperparathyrosis. If it is primarily hyperparathyrosis, but the vitamin D is low, calcium is at least not higher than 2.93, I evaluate positively vitamin D, because secondary hyperparathyrosis can influence to the change of hormone level. And if the patient with osteoporosis with primarily hyperparathyrosis, it is indication for surgery intervention, and it can be predisposition for hyperpotassiemia, but the blood calcium should be controlled all the time. Thank you so much, Marina. I think the last question is to you. The patient 28, autoimmune thyroid, hypothyrosis, L-tyrox, and it is frequent systole. Is, as far as I understand, patient is taking euthyroxine. Yes, the patient is on thyroxine and hypothyrosis. The young patient, 28 years, we need to avoid low levels of TTG. Probably we'd better keep to the middle level of TTG, not any more particularities, just independent treatment of extrasystole. Thank you so much. And what do you think? Can we prescribe metformin when it is gestational diabetes? I think it is possible. I do prescribe it. It depends where you live. In the Russian Federation, you cannot prescribe it. It is not registered, right? Yes. The question about metformin. Yes, yes. In the Russian Federation, a tablet sugar decreasing are not approved for pregnancy, for pregnant patient. In some countries, these drugs are approved for the second line when insulin therapy is not approved, or when patient rejects insulin therapy, then these drugs can be prescribed. In half of cases, the insulin therapy was needed. In Russia, we cannot prescribe metformin. Thank you so much. Thank you so much, dear colleagues. We had a very interesting session. We cannot answer all the questions, but we are already 20 minutes behind the schedule. It was very interesting. I loved all the presentations. Thank you so much. Thank you.
further ado, let's move on. The first presentation is called Arthralgia in the Post-COVID Period. The floor is given to Pavel Novikov, Moscow, Russia, please. Thank you very much, Andrei, dear colleagues. Indeed, rheumatologists and COVID-19 are inseparable, and you can see that our clinic has been reprofiled 4 times to treat patients with COVID-19. We understand that the new coronavirus infection continues to be a serious problem, especially for vulnerable groups of the patients who are on immunosuppressants. And besides that, there is a wide range of articular or autoimmune manifestations which can occur as a result of the new coronavirus infection. What should be done in this case? How can we interpret these problems from the practical point of view? So this is the theme of my presentation. Let me just remind you that COVID-19 is a very relevant issue, despite the fact that right now, thanks to vaccination and the introduction of antibodies, new types of therapy, and also the post-infection immunity, the burden related to COVID-19 is much lower. But nevertheless, patients still have COVID-19, and patients are being hospitalized for COVID-19, and we still have quite a significant mortality rate. Of course, it is much lower as compared to the peak of the infection way back in 2020, 2021, but still the problem persists. Also, there are quite a large number of patients who have had COVID-19 all over the world, and right now about 700 million people have had COVID-19 at different times. And of course, their immune system has changed after COVID-19, and it also affects a large group of people. And we're talking about real cases, and these parameters can even be much worse. Well, of course, as for the consequences of COVID-19 for society, the structure of strains has changed. Right now, we're in a period when the most widespread strains of COVID-19, SARS-CoV-2, is the Omicron variant, but we can see now that Omicron do not cause severe cases all too often, especially when the lung tissue is involved, and it doesn't lead to uncontrolled forms of the disease. But for vulnerable patients, especially those who have comorbidities, those who have rheumatoid problems, those who are on immunosuppressants, even Omicron strain continues to be a serious problem. Suffice it to say that Omicron has its own peculiarities of manifestation, such as organ failure, myocarditis, acute kidney injury, and of course, they occur much more often as compared to other COVID-19 strains. And what is important is that the inflammation syndrome due to the hyperactivation of immune system, which in itself has the damaging effect, well, hopefully right now we occur a lesser number of such cases. And there is another aspect of interaction between infectionists and rheumatologists. The instruments used to suppress this hyperinflammation, which occurs as a result of the COVID-19 infection, is the use of anti-inflammatory drugs, targeted anti-inflammatory drugs, also low molecular combinations. And of course, it is important to remember that there has been a change in our perception of the COVID-19 infection. Right now, we realize that there are 2 stages. At the early stage of the disease, this is a viral disease, and it is quite obvious that during the first days of the disease, we should use ethiotropic therapy as much as possible, using low molecular antiviral drugs, also using virus neutralizing antibodies, which are quite active as far as specific strains are concerned. But then there is a shift. The major damaging factor is not the virus, but our own interactive immune system. And here, treatment must be based on preventive therapy or anti-inflammatory therapy. For that, we use glucocorticoids and drugs blocking J kinase, interleukin-1, and of course, drugs impacting on interleukin-6. So this hyperinflammation leads to multi-organ failure in case of COVID-19, and it is hyperinflammation and its consequences that lead to the development of the mechanism of the so-called post-COVID syndrome or long COVID, consequences for health which persist for a long period after the resolution of the infection per se. It is important to say that factors that determine the severe course of COVID and increase the probability of the formation of the post-COVID syndrome are concomitant diseases. These are the diseases which have the highest epidemiological burden in the population, such as diabetes mellitus, cardiovascular pathologies, kidney chronic diseases, lung diseases. So they determine the poor outcome of COVID-19 treatment and also poor prognosis. And also, they're also the factors for the long-term negative consequences of COVID-19. We must also remember that modern treatment of COVID-19 is not only ethiotropic or anti-inflammatory therapy, but one of the tasks of our treatment of COVID-19 is the preservation of the structure and functions of the tissues. So we must provide care for patients with active infection and at the same time think how to avoid long-term consequences. That is why therapy must be timely and complete. Unfortunately, when we administer anti-inflammatory drugs at the later stage of infection, here we have a lesser chance. We do not have any guarantee that this anti-inflammatory treatment can be effective. It can be enough to prevent the progression to more severe forms of the disease. And you can see that among all the problems of COVID-19 means that rheumatologists must also be involved as specialists from other fields, and especially the post-COVID syndrome poses a serious problem. Right now, there is no final terminology like long COVID or PASC, post-acute sequelae of COVID-19. There are different variants offered here, and of course, in English literature, it's a PASC. Speaking about terminology, we can talk about PASC or long COVID. Well, these are the symptoms which persist for more than 3 months after the confirmed or possible COVID. These symptoms usually persist for a long time, and there are no alternative explanations for such symptoms. In speaking of the long COVID, usually there is malaise, fatigue, shortness of breathness, cognitive dysfunction, different types of pain syndrome. Here are the patients with pain syndrome, and usually they have pain in the muscles and they come to a rheumatologist, and we have to interpret this situation. We do the differential diagnosis, trying to find a wide range of different rheumatic diseases. In speaking of the post-COVID syndrome as a clinically important problem, these must be symptoms which have a strong impact on the daily activity of an individual. They should lead to significant limitations in life. The frequency rate of such symptoms varies, and of course everything depends on the methodology of the study. It depends on the approaches used by the authors of the study, but the general frequency rate of long COVID can be 10% and even more. There is a link with the severity of the infection, although severe complications can occur when the long COVID was not quite severe. Usually, such problems more often occur in women, and usually they are related to comorbid conditions. And I should say the question is still open. Yes, autoimmune diseases can lead to a higher frequency rate of post-COVID syndrome. Well, as for the reasons for pain syndrome and other manifestations of PASC, they're not quite clear. Probably there is the persistence of the viral infection or some other residual viral particles. The proof of that is the morphological studies, which have shown that, yes, for a long time, there may be the preservation of the virus in the organism or viral particles. Also, there may be autoimmune mechanisms involved, and later I will discuss a wide range of different antibodies that can be detected in patients after COVID-19. It is quite possible that there may be complex relations between different immune autonomous elements of our organism. In particular, there are microbiome, which is changed. Also, there are antibodies to different receptors responsible for the transduction of the signal. Also, there may be the damage to the central nervous system per se, due to the damage not to neurons, but to real structures responsible for the normal functioning. That is why mechanisms vary, but this is the usual situation when there is no just one particular reason for that. Suffice it to say that the question of articular syndromes that can occur after viral infections has been studied for a long time. Well, at the very start of the pandemic, in the Nature Review of Rheumatology, an article was published devoted to articular syndromes, not only caused by SARS-CoV-2, but also due to other infections. This review showed that, in fact, coronaviruses are not the etiological pathogens that can provoke some particular arthritis. So when you take specific, when you had specific infections, well, there were cases of arthralgia or myalgia, but there were no confirmed cases of reactive arthritis or persistent arthritis, unlike other viruses, because hepatitis C, well, for example, often provokes persistent joint problems. The same is true of parvovirus B19, hepatitis B, rubella, but as for coronavirus and the flu virus, well, can be the reasons for arthralgia, but as for arthritis, we do not consider, well, COVID-19 as one of the causes of arthritis. And, well, you can see that right now the frequency of arthralgia in the post-COVID period can be up to 27%. There were also cases confirmed of reactive arthritis after COVID-19. There are also cases of the inflammatory arthropathies after COVID-19, such as rheumatoid arthritis, for example. They do not occur all too often, but nevertheless, they do occur. Also, the virus-induced arthritis, well, are not very widespread, but we continue to analyze the data. Right now, we cannot say with absolute confidence that SARS-CoV-2 causes such chronic diseases. The same is true of myalgia. Well, muscle pain occurs quite often, from 20 to 30%. There were cases when there was short myalgia in the post-COVID period. And also there were cases of myasite in the post-COVID-19. And it is also important to say that the data we have now do not allow us to develop some particular strategy to treat arthralgia, which is formed in the post-COVID period. Later, we'll talk about the management of such patients, but right now, well, the treatment should be empirical and should take into account the comprehensive assessment of the situation. An important element of this situation is the clinical characteristic of the pain syndrome, because traditionally, when we're talking about pathology, the main differential diagnosis is made between the inflammatory and the mechanical nature of joint involvement. And when we analyze the post-COVID arthralgia, this is one of the major problems, the inflammatory nature of pain in joints. Of course, in this case, we're talking about the further examination to identify the cause of inflammation, and then anti-inflammatory treatment will be administered depending on the situation. In any case, we're talking about the inflammatory cause of pain. If it's the mechanical cause of pain, the approach will be absolutely different. And of course, as for the pain syndrome, we should take into account all the reasons. There might be cases of severe neuropathy after infection, also after the Guillain-Barré syndrome, and in some cases, this syndrome requires differential diagnosis, including the involvement of neurologists for making the right diagnosis. Let me just say a few general things, and one of the key characteristics of reactive arthritis is the duration of the disease. In most cases, it lasts from 2 to 8 weeks. So quite rarely, there is a situation when arthritis lasts for more than 3 months. The key characteristic of reactive arthritis is that after 1.5 or 2 months, we can see that the disease resolves itself or due to therapy. And if arthritis is confirmed that there is inflammation and it persists more than 6 months, so here we have grounds for some alternative explanation, including chronic inflammatory arthropathy. The situation is complicated by the fact that long COVID is often associated with the change in the spectrum of antibodies during the infection. Up to 70% is the frequency of the detection of anti-nuclear factor. Also, we can basically identify different antibodies, and I should say that this acute situation is not clinically important. Well, we can also have such cases as ANCA, and of course, that's anti-neutrophil cytoplasmic antibody. Sometimes patients can have the persistence of the inflammatory syndrome if C-reactive protein ferritin D dimer is slightly elevated. In this situation, there is no need to have any further examination. Well, the administration of such markers or their elevation can worsen the post-COVID syndrome, but this situation merits the most serious consideration. Another problem the dermatologists occurred is also the frequency rate of detection, and also one of the factors leading to complications is the use of glucocorticoids. Well, of course, glucocorticoids can lead to serious problems, especially dexamethasone. It can lead to acute necrosis. Well, the main method of diagnosis is MRI. Also, there may be different types of treatment developed, but right now we have also vasoactive substances that can be used for treatment, or at least to control acute pain syndrome. In conclusion, I would like to say that we must be practical in managing such patients. We must rely on routine lab tests depending on the clinical picture, take into account systemic inflammation markers, take into account our systemic markers that we have been using to diagnose arthropathy, and also to assess the severity of the disease per se. And we understand that in some cases, a dynamic follow-up is one of the possibilities here. Then systemic therapy can be started with anti-inflammatory drugs. We should also be careful in the use of systemic steroids, even if we have the systemic inflammation, if the nature of the disease is chronic. In this case, we can discuss the use of sulfasalazine, methotrexate, and of course, in the post-COVID syndrome, well, anti-interleukin 6, anti-interleukin 1 or JAK kinase can be used. And of course, in this case, we can stop this persistent inflammation, but we should also remember about the nosological use drugs if patients have rheumatoid arthritis or some systemic manifestations when active inflammation persists. Thank you very much for your attention. And that's all there is to it. And please join our educational project at our clinic, which started in March. And I hope this project will be expanded due to your participation. Thank you very much again. And I'll be able to answer your questions during the Q&A session. Thank you very much, Pavel. I hope there will be questions that we're going to discuss later. Let's move on to the next presentation, Gout Best Practice 2023. Professor Bashkirov, St. Petersburg, will be speaking on the subject. Distinguished colleagues, esteemed members of the symposium, today I would like to discuss the problem of gout, which is widespread. This is the systemic disease characterized by the deposition in different tissues of monourate sodium and can be explained by different genetic factors. And I should say that the incidence rate is higher among men, and also it depends on age. Well, as for pathogenesis, I'm not going to speak about this in detail. Hyperuricemia, as you can see it here, which is the formation of the crystals, also the signal TLR2 and TLR4. Also, you can see endothelial activation, neutrophil recruitment and activation. Other soluble pro-inflammatory mediators can be induced. And of course, you can see we'll be discussing this more in detail as part of this Congress. And of course, gout can be linked to chronic hyperleukemia, and of course, monourate natrium crystals can activate the toll-like receptors and can lead to inflammation. And in this case, well, you can see that they can activate different inflammatory factors. They can activate NLRP3 inflammasomes, and later this inflammatory reaction continues to exacerbate. And of course, there may be active neutrophil inflammation. And in the future, you can see there will be the accumulation of such crystals that further leads to chronic arthritis. And of course, we can have an impact on this disease. First of all, we can block hyperuricemia, and I'll talk about that later, but also it can lead to the stoppage of the progression of the disease. we can also block the inflammatory processes and stop the acute manifestation of arthritis. Well, here you can see chronic gout cases when there is a deposition in different joints, and you can see here some of the pictures, and the most unpleasant thing is that this infection can contact with the external environment. There is not enough blood supply, and this can lead to severe consequences. So the key pathogenetic factors of gout are shown here. We have partially covered this issue. First of all, there may be genetic predisposition, hyperuricemia, activation of the inflammation, hyperproduction of uric acid, also hyper-excretion of urates such as urate1, GLUT9, ABCG2, etc. to mention. But if you ask for the diagnosis of gout, it is based on the combination of clinical manifestations plus the results of examination, the data of lab tests, and the instrumental tests. You can see the criteria for diagnosis by Wallace of 1977 and ACR 2015. Well, and of course, you can see that right now, dear colleagues, I should say that there may be oligoarthritis or clinically manifested arthritis. Well, of course, you can do the physical examination, you can do the biochemical analysis, you can do the biological tests, and of course, we should take all these factors into account. That's very important, especially when the patient has some infections. And naturally, as for doubt, well, microscopy tests can be used to make the right diagnosis. Polarization microscopy has been used for several decades. It is recommended because in this case, it is quite reliable. Unfortunately, sometimes it's not quite possible to do it in all cases, but I should say that this is the standard, and of course, this allows us to make the right differential diagnosis. The ultrasound or IVUS, well, this is as good as traditional microscopy. We can get a lot of information. We can get the information about the double contour, the information about tophi, that is the deposition of crystals of uric acid in tissues. We can see if there are any erosions, and you can identify different non-specific manifestations. As you can see it here, you can see metatarsal head involved at the left top of the slide. Well, dual energy CT allows us to see the anatomical structures and tissues. Well, you can see that they can have the same or different density depending on the energy of the X-ray emission. And also you can see there may be different other complications, and you can see basically X-rays here. Well, dual energy CT is more expensive, but we can get more detailed information. X-ray, of course, is one of the standards of diagnosis, but unfortunately, X-ray cannot give us a lot of information in case of gout, but we can get quite enough information to make specific decisions. We can see usually changes at the later stage of disease. That's one of the drawbacks of the X-ray. This is the later stage of the disease, but nevertheless, we can make the differential diagnosis. Here you can see the criteria of acute gout arthritis according to S.L. Wallace of 1977. First of all, we should identify the typical crystals in the synovial fluid, also the presence of tophi, and also, we can use polarization microscopy to confirm the presence of tophi, and at least we can identify no less than 6 out of 12 signs shown here. In this case, we can say that this is arthritis, such as skin hyperemia, or, for example, one-sided damage of the foot, also suspicion of tophi, etc. Here you can see the modern criteria of diagnosis. According to ACR, EULAT 2015, more than 8 points. You can see the criteria and categories and points. Arthritis and crystals are one of such criteria. If we did not identify them, see if any joints are damaged. Also, the level of uric acid. This is very important, and of course, lab tests are of paramount importance here. At the same time, we can see that sometimes we do not get a lot of information using just imaging methods. Well, but you can see that imaging methods can help us visualize different signs of deposition of urates. And here you can see the criteria for gout diagnosis according ACR, EULAT 2015. And as for treatment, right now, gout should be treated by way of controlling acute gout arthritis, also removal of hyperuricemia, and also we should correct comorbid conditions which such patients might have in this situation. And of course, patients with comorbid conditions have the worst outcome. And of course, when we control comorbid conditions, this will have the positive effect. Here you can see the mechanism of therapy according to EULAR 2016. And here you can see specific algorithms, what should be done in a particular situation in order to control gout. For example, when we should start with the awareness of the patient so that the treatment could start as early as possible. And of course, that means changing the lifestyle, assessment of the concomitant pathology and the drugs administered to this patient, then the selection of the tactic of treatment depending on the severity of the disease. And we can administer colchicine, low-density lipoproteins. For example, as for colchicine, it's usually 0.5 milligrams every hour, but it did not show very good results. Well, low-density lipoproteins, well, that's a very important class of drugs. They have a good effect. Well, usually reduce the severity. Well, as you can see it here, well, prednisolone is the third method of treatment. Also, injection of glucocorticosteroids and combination therapy, for example, colchicine plus low-density lipoproteins, or colchicine plus glucocorticosteroids. So you can see each method of treatment should be chosen depending on the comorbid conditions that the patient has. And of course, we can do it depending on specific case. Well, just look here. Here we can see the therapy using low-density lipoproteins or glucocorticosteroids, so colchicine, and urate-reducing therapy is shown here. It is indicated for all patients with persistent hyperuricemia and acute attacks of arthritis. The goal of the therapy is to maintain the level of uric acid in the blood serum lower than 360 over 300 micromole per liter. It is not recommended for the long-term support of the level of uric acid in the blood serum less than 180 micromole per liter, and it is contraindicated to start urate reducing therapy during the acute gout, especially when there is the clear manifestation first. The clinical symptoms of gout should be removed, and only then you can start this kind of therapy. So you can see the presence of tophi less than 300 micromoles per liter. And of course, if possible, diuretics should be cancelled. Losartan can be used, or statins, or fenofibrate, and we start the prophylactic treatment up to 6 months using colchicine or low-density lipoproteins. And then we start the urate reducing therapy. Well, for example, we can use allopurinol, 100 milligrams per day, and then we adjust the dose depending on the kidney function. Or when there are no tophi, well, in this case, the dosage is less than 360 micromole per liter. Or when there is the intolerance of allopurinol, in this case, we can administer febucostat or uricosuric. Thus, when the goal is achieved in terms of the level of the uric acid, well, again, when the goal is not achieved, allopurinol can be replaced with uricosuric. If the goal is achieved, we continue this therapy. If not, we can use the combination therapy. As you can see, the algorithm is quite clear. Non-medical therapy, well, that's proper diet with the low level of red fish and seafood. Also, minimization in the consumption of drinks that has fructose, well, such as different energy drinks. Of course, the rejection of alcohol, any kind of alcohol, also maintenance of the optimal body mass. And of course, here you can see the non-medical therapy. That's basically the Mediterranean diet. And again, you can see what should not be used in this case and what should be used. So as you can see, the level of uric acid can be reduced by administering this non-medical therapy. Well, here you can see the impact of other substances on the level of uric acid in the blood serum. Allopurinol is a very well-known drug. It's the structural analog of hypoxanthine, and it's a first-line drug. As you can see it here, well, it can lead to adverse events such as hypersensitivity, and also there may be some counterindications such as pregnancy or lactation and other situations when allopurinol should not be administered. Well, febuxostat is a selective non-purinol inhibitor of xanthine oxidase. Well, it metabolized by the kidneys. It is more preferable in patients with a kidney pathology. And of course, usually the response to this drug is very good. It is quite effective. There may be such adverse events as hypersensitivity. It is not recommended for pregnant women. Well, you can see uricosuric therapy, such as benzobromide, and also lesinurad and other drugs, and also uricase drugs that can usually periurethric uricase produced by Escherichia coli, which may lead to negative effects. Well, you can see it here that there might be the inhibition of the production of uric acid. And of course, you can see tuna extracts, Levotor, Fizopam. Also, there are also new drugs being developed right now, such as topiroxostat and others. Studies are still underway. Dear colleagues, thank you very much for your attention. Thank you very much, Roman, for this wonderful presentation. We are doing okay right now. Professor Melnikov from St. Petersburg will be talking on rheumatoid arthritis. Please, Professor Melnikov, the floor is yours. Well, good afternoon, dear colleagues, esteemed guests. Today I'll be talking about rheumatoid arthritis, best practice 2023. Rheumatoid arthritis is a systemic disease. Joints will be involved, but other organs as well, and we should pay attention to that. The incidence rate of rheumatoid arthritis is not very significant, but there are specific centers, rheumatoid departments, where a lot of patients are being treated. The incidence rate among women is higher than among men, and I should say, usually the cohort of people of working age is being affected by rheumatoid arthritis. Not all arthritis can be called rheumatoid arthritis. In case of arthralgia, it is important to do the differential diagnosis to determine whether the patient has rheumatoid arthritis or not. And I think we've seen different pictures with such patients when we do not have any doubt that the patient has rheumatoid arthritis. But as for the typical stages such as contracture, etc., well, but our task in 2023 is the early diagnosis of rheumatoid arthritis, early start of treatment, and our ability to avoid any complications caused by rheumatoid arthritis or any severe progression of the disease. As for arthralgia, I should say that, well, rheumatoid arthritis may not develop from arthralgia, but as for some patients, they should be monitored more carefully. Well, I should say that articular syndrome can be of inflammatory nature, while rigidity can be up to 60 minutes. Also, the patients can have a high risk of the development of rheumatoid arthritis. Synovitis, well, can also be one of the signs of the development of rheumatoid arthritis, and as well as rigidity of joints and localization, especially when we are talking about the interphalangeal joints, and also when we examine the patient or when we do the palpation, there might be an increase in the temperature of joints, and the positive test when we press on the palm, the patient may have some pain. This is a very good method of diagnosis. Well, also you can see the palm of the patient with rheumatoid arthritis. We can see synovitis, and besides the clinical picture, rheumatoid arthritis is the diagnosis that can be made clinically. Lab tests and experimental tests can be of great help here. As for different indicators, we can see elevated C-reactive protein, etc.
But for that, we cannot forget that patients with rheumatoid arthritis can get drugs that are reason to be non-deficit and leukopenia. As for thrombocytosis or leukocytosis, this is quite manifested in active rheumatoid arthritis caused pro-inflammatory cytokines that participate in inflammation have pleiotropic effect. They evoke high phase, characteristic and systemic reaction. And we can see megachrysita or megaproductive phase with increase of leukocytes. There are less specific markers of rheumatoid arthritis, rheumatoid factor, and due to the high sensitivity, though it is highly sensitive, it is not very specific. And there was a number of diseases when rheumatoid arthritis can be increased. When we don't see typical joint syndrome, or if you don't see joint syndrome at all, but rheumatoid factor is increased, it is a call to follow these patients, to follow up this patient, because it can be chronic infection of upper airways, and can be during to oncology diseases. Rheumatoid factor can increase and it would not be rheumatoid arthritis. Most sensitive marker is antibodies to cyclic citrullinide peptide, and if rheumatoid factor is negative and we have joint syndrome, and these antibodies can be of a big help. Antibodies to cyclic citrullinide, vimentin, can be detected also in special clinics. I would love to mention that these data, these antibodies to vimentin, to peptide, are not associated with the activities of the disease. It can be aroused quickly. Sometimes our cardiovascular system is more influenced. But we can, due to this factor, we do not correct therapy of this disease. Rheumatoid arthritis, it's not only joint. Joint is the peak of the iceberg. We can see systemic issues that from time to time, there can be seen in 30 to 50 cases. Most common are rheumatoid nodes. So sometimes we can see as Sjogren syndrome, and so on. Due to its systemic effect, it can lead to a number of issues, and atherosclerotic disease of the vessels and myocardium is described, and it can be the reason for myocardial problems. And we see also here problems such as acromegaly, arthritis, and so on. Systemic problems can be quite different, not only like they are seen here. Of course, we see rheumatoid nodes, lymphadenopathy, liposcleritis. We see the biopsy here in the secondary Sjogren syndrome and serositis. It can be accompanied by chronic syndrome of intoxication. Patient kind of feels himself all the time as if he has flu, and it does not disappear. All the symptoms, all the lab. When we collect it, we set a diagnosis. The diagnosis that can be treated better, and the classification criteria were developed. And here we calculate the number of the books, the number of the scores, the clinical marks. We can see here this specific sign as arthritis, as if it is arthritis. And it is important to understand how long arthritis lasts already. And when we exclude other reasons, then we set the diagnosis. After we set the diagnosis, we start treating of rheumatoid arthritis. If we set the diagnosis, we'll definitely have some activities in blood, and we have to start the treatment with basic therapy. But to understand what is the volume of treatment, we have to see the activity of the disease. And there is evaluation on WASH and CRB and EGFR. There are also certain marks that demonstrate to us that treatment of these patients can be quite complicated. And it can be different type of the disease, even if we prescribe a basic anti-inflammation drug. High level of ESR and CRP, we used to think that a lot of swelling joins, the joints with some inflation, early erosion, and inefficiency of 2 or more anti-inflammatory diseases. You see the patient with the patient rheumatoid arthritis. You see here subluxation. This is a patient with certain long-term rheumatoid arthritis, and we see ankylosis here as well. To start the treatment, it is not a must to have rheumatologist. Of course, it would be better if there is some consultation from rheumatologist. I'm not talking about basic situation here, but some initial therapy can be provided by any doctor. First of all, we prescribe non-steroid anti-inflammatory disease, and we can continue them even when we prescribe basic drugs to get the cumulative effect. We can also use glucocorticosteroids. An important thing here is that today we try to decrease the time of glucocorticosteroids in the smallest possible dosages. And what is most important, where do we pay attention? Deterioration of rheumatoid arthritis means that the basic therapy is not correct. Either we do not give combined drug. There is some issue with basic therapy. Intravenous glucocorticosteroids recently are not used widely. Of course, there can be cases of active diseases, such as psoriasis, and they require introduction of the drugs. In some monopolic arthritis, we can consider intrajoint injection of glucocorticosteroids. The most important here for rheumatoid arthritis is achieved by prescription of basic drugs. The golden standard here is methotrexate, and we need to accumulate it up to 3 milligrams per kilogram. We prescribe 10 milligrams. Then we evaluate it. And we evaluate the situation with the lab tests. And the clinical evaluation of the result is evaluated in 3 months. And if we do not achieve remission, it's a reason to think about changing the basic anti-inflammatory drug. Because this drug has a wide range of side effects, it is described in the label. We can always explain to the patient that methotrexate has a wide range of dosage from 10 to 1,000 milligrams. It is important to explain to the patients that the side effects can include these big dosages, these high dosages. We need to control clinical analysis, clinical blood test to exclude thrombocytopenia, erythropenia that can deteriorate in these cases. It is important to notice, as this drug blocks the cycle of folic acid, it is important to prescribe a folic acid to prevent complications. I would say probably some provocative say, we always thought that folic acid should be prescribed 24 hours after methotrexate. The last in vitro studies, it was demonstrated that folic acid does not compete with methotrexate and it does not change the efficiency. If it is not efficient, the second drug is leflunomide. Dehydrogenase blocks the cell cycle. It does not allow to proliferate T lymphocytes that activate the further signal. The big disadvantage of this drug is that it is not prescribed to ladies of if we should always ask whether they plan pregnancy. There must be 2 years before the woman becomes pregnant when she takes this drug. And there is also hydroxychloroquine and sulfasalazine. This prescription is limited when we see low activity of rheumatoid arthritis. If we do not achieve fully our effect, we prescribe gene engineering biological therapy. These are necrosis factor, tumor alpha inhibitors, anti-interleukin, anti-receptors, and Janus kinase inhibitors. We evaluate here definitely chronic infections. And they require rheumatological clinic, and we have to understand, of course, why the patient can have very often infections. And we have to say this to the patient so that he informs his treating doctor. As for the mechanism of action of this drug, it is all around macrophages, antigen-presenting cells, co-reception interleukin that are registered for rheumatoid arthritis, but as they are quite expensive, they are not used everywhere. The inhibitors, interleukin-6, rituximab, and usually it is used in systemic demonstration. And moreover, we see lots of studies that are aiming different therapies of rheumatoid arthritis. As for monitoring of the therapy, the patients are getting non-steroid drugs. So what are the regular complaints of the patients? We always need to decrease glucocorticoid values, and it should not be longer than 1 month. It influences the retina, and these patients need to have consultation from ophthalmologist. and sulfasalazine methotrexate, we have more or less same side effects, and following these drugs, we see that before the biggest risk, we see it in our patients quite often, and we then start following them if just 4 to 6 months. The patients on the therapy of rheumatoid, they can come when they are pregnant, and some of the drugs are not recommended to use it. For example, methotrexate. We used to think that more than 6 months, there can be methotrexate, but in some literature data, we say that it's from 1 to 3 months. Leflunomide is not recommended, and it is contraindicated in breastfeeding. And as for gonads and tertide genes in people, sulfasalazine does not deteriorate. Methotrexate in the last data does not, and leflunomide does not provide us enough data. So our main task is timely verification of therapy and its control. We can achieve good effect, and this would be important for further prognosis for the lifespan of our patients. Thank you so much. Thank you so much for your presentation. Good afternoon, dear colleagues. I hope you see me and feel and see my presentation. We continue our work. As we have time deficit, I will speak fast. I'll talk about spondyloarthritis. It is a group of inflammatory rheumatic diseases. There are different diseases, and today we know that domains that are associated with axial disease, when we see sacroiliitis, colitis, and different inflammatory diseases of IG. What is the main difference of concept of spondyloarthritis? All the spondyloarthritis can be divided into 2 groups, axial and peripheral spondyloarthritis. But most important, what we discussed recently, it is a non-X-ray spondyloarthritis and X-ray spondyloarthritis. And the question was whether these are 2 different diseases, or non-X-ray is the early stage which transforms into X-ray stage. At the moment, we consider that as a disease that is called axial spondyloarthritis. A part of the patient has it as non-X-ray spondyloarthritis, and it can last for years and thousands of years, during which we have clinical symptoms of the disease, certain inflammation on MRI, but we will not see the typical changes on the X-ray. With time, it decreases, this cohort decreases. As for X-ray axial spondyloarthritis, we can see that there's changes in sacral iliac joint and changes in the spine. Totally, it is considered as axial spondyloarthritis. In 2024, And we have ASOS positive. And we have this ASOS positive and the classification of ASOS in MRI studies of T1W. We see the fat metaplasia of bone marrow. In STEER regimen, we see bilateral inflammatory lesions of the bone marrow and bilateral inflammation in the joint line. And in CT, we see erosion zone and sclerosis. Combination of these characteristics demonstrate that we have sacroiliitis. This is a typical problem in spondyloarthritis. Spondyloarthritis is even more often than rheumatoid arthritis. We discuss it is more than 1.5% in population, and we see ankylosing spondyloarthritis. And fact, the spread of the disease increases, but the diagnostic of this problem is still significant. Today, see that the diagnostics used to be 6 to 7 years, but today it's from 2 to 6 years. And these are the diagnoses in men and women who have spondyloarthritis. These are there are peripheral, axial, bone and marrow lesions, inflammatory disease of GI, just pain, depression. So many diagnoses we have in women. The number of these preliminary diagnosis and the coding is most often than in men. Women address for medical help more often. They have diagnosis of few diseases, and during 2 years, they have to come for the help more often before the diagnosis is verified. Unfortunately, diagnostics of axial spondyloarthritis, including ankylosing spondyloarthritis, is a huge problem. There are significant difference between clinical picture of spondyloarthritis between men and women. You see that men have the interleukin 17 and FNO, and there are more probable rentgenological X-ray changes of sacroiliac joints. Sclerosing process is faster in men, and decrease of the flexibility of the spine and lumbar part. They have these limits earlier. Ladies have a lower level of inflammatory cytokines, lower level of interleukin 17, but women has worse joint state. They have lower life quality, depression and anxiety are more common in women. They can be seen neuropathic pain, and it's more common in women. They have fatigue, functional issues, and women have more common peripheral and upper axial picture. This it is more common when progression in women is in neck, and that's one of the reasons that women are waiting for the diagnosis longer, because there are peripheral signals of the disease itself. The criteria of axial spondyloarthritis exists for a long time already. Rheumatologists know them. They discussed it in therapeutical sphere, we discussed the chronic pain in spine that appears in patient in the age 245, and the most common disease in the patients aged 25 to 30 years. Sacroiliitis is very common, and I marked with red inflammatory pain in spine, in back. And this is very important. Therapist has and must evaluate inflammatory pain in spine. When we have this inflammatory back pain, is one of the most common reasons to address physicians. So what is quite characteristic for this inflammatory pain in spine? The pain increases during night and the patient cannot sleep. It is various pain in both buttocks and there is some kind of restraint, stiffness, and the patient needs to perform some exercises to overcome this stiffness, and a good response for non-steroid anti-inflammatory disease. Why we cannot still diagnose spondyloarthritis? Because they answer well non-steroid anti-inflammatory diseases. The progression is most common, less common in women. There is no specific biomarkers, and the physicians of the primary chain sometimes send these patients to these patients are sent to a neurologist and not to a rheumatologist. For therapists, for the patients of other specialties, the message of our today's discussion is as following. All the patients with the chronic back pain started in age 45, and you collect anamnesis, the pain from young age in the back, and if the patient has this pain in buttocks, there is improvement when the patient moves. If there is psoriasis, we have to send this patient to rheumatologist. Sometimes patient comes to rheumatologist with positive result of rheumatologist. If we send the patient to rheumatologist, not all the patients would have this verified diagnosis of spondyloarthritis. We can see spondyloarthritis and the method of treatment. We have recommendations from 2019, American recommendations. Our ankylosing spondylitis. I will not talk about all the details. What's new in 2023, I'll just say that we have recommendation of ASUS, of spondyloarthritis. And there are certain important stages and recommendation. First of all, this is a disease that requires multidisciplinary treatment. Multidisciplinary treatment is very important. We need to talk about situation where the team is led by a rheumatologist. It is important for the patients with axial spondyloarthritis, characteristic for different diseases. And you can see that it's most common than in population. And you can see that seen in patients with chronic arthritis and so on. Today we've had special studies that demonstrate that hypertension is not defined by anti-inflammatory non-steroid drugs, but it develops before the start of treatment, and the longer diagnosis is onset, the more probable hypertension is. It is associated with the health control of syndromes. The experts here stress that it is inflammatory disease, and if we want to preserve the life quality, if we want to prevent progression, we need to cope with activity, we need to cope with the inflammation. It is described very clearly in the guidelines. We have to combine non-medical and drug types for treatment, and actually it works for all the diseases that we discussed today. But for the patient with axial spondyloarthritis, it is one of the most important positions, because non-medical treatment is an important part for the treatment of the patient. And of course, it is stressed that today, keeping in mind the diversity of the drugs that we have to have joint decision of the patient and the rheumatologist to decide on the drug to control the activity of the disease. As for recommendations, and we have to based on the algorithm. It can be every time individual therapy with axial peripheral issues, extra muscle symptoms, and of course there must be a therapy. As for monitoring, if we talk about rheumatoid arthritis, we have to pay special attention to what is said by the patients, their feelings. As the clinical tests, and of course, as does our most important criteria to evaluate the efficiency. We have to understand the purposes of the treatment. And of course, it's important to perform all the physical exercises. And this will help us not only at home, but of course, if the exercises are performed under the physician's supervision, they can be even more efficient. The patients suffer from pain and from stiffness, and non-steroid anti-inflammatory diseases are most important. The recommended dosage for all non-steroid drugs. What is the novelty here? We know that prescription of non-steroid anti-inflammatory diseases in the maximum dosage on everyday basis block or slow down in irreversible changes in the spine, but in the position that we have in guideline number 5, experts state that the dosage choose is important to arrest the pain right now and here. And this is important for the dosage of drug. Again, I will reiterate, non-steroid anti-inflammatory drug is very important. And this is a therapy that can support us in different regimens. As for glucocorticoids, it is only local injection. We do not talk about systemic glucocorticoids, and the experts stress that no studies were performed for the efficiency of glucocorticoids for patients with axial spondyloarthritis. The efficiency of drug is still here, so we can use them. Synthetic basic drugs should not be used. We can talk about sulfasalazine here in patients with peripheral arthritis, and gene-engineered therapy and blockades of Janus stenosis in patients with preserved high activity. What starts with the inhibitors. And look at this wording that appeared in these guidelines as recommended in the current practice. And we can talk about the FNO factor, FNT factor, because we have more. If there is no effect, we can go back to the diagnosis. We have to be sure that the patient really has spondyloarthritis. And we know it in our everyday practice, especially if it is non-X-ray. We can verify the diagnosis when we are sure that it's spondyloarthritis. And as it is recommended, including Janus kinase inhibitors, if the patient is in the remission, we can decrease the dosage, but the experts do not recommend discontinuation of the therapy. And if there is something with the patient when the disease process changes, we have to check all the variants, not only the activation of inflammatory. There can be fractures of spine, and it must be, of course, imaged. And for the physicians, first of all, if we have the patient with the back pain, we have to exclude inflammatory or prove inflammatory pain. The therapist can prescribe, the physician can prescribe the first line drug, anti-inflammatory drug. Rheumatologists today have recommendation to use 3 groups of drug: interleukin 17, Janus kinase, and necrosis factor inhibitors. And of course, we have to remember about cardiovascular system, and we have some time. Let's check what we have in the chat box. Thanks, dear colleagues, for your wonderful presentation. We have a lot of factors. I don't see Pavel. I will reiterate, more than 3 months in the signs are still here. Roman Andreevich, if the patient already has EUAT decreasing therapy, do we need to discontinue it in deterioration? And the patient already gets this therapy, we have few possibilities. Some schools say that we have to discontinue the drug. Some schools say that we need to continue the drug. In our clinic, as the date of many studies, we divide the drug to 50%. And then after the deterioration, when the urine acid, shall we discontinue the drug? And dear colleagues, when the urine acid decreases, we need to decrease the dosage of the urine decreasing drug to the minimum dosage, for example, up to 100 or to 50 milligram, or we can use it every other day. If we see still hyperkalemia, we can discontinue urine decreasing therapy, and then we decide. There are different variants that are possible. There are always questions about symptomless hyperuricemia, whether it depends on the level of urine acid. It is a good question. In this case, we have to pay attention to the comorbidities. If the patient has serious cardiovascular risk, if there is a wide range of comorbidities, we can use urine decreasing therapy if the uric acid level is on the high level. In many guidelines, as for official documents, Cardiological Society and consensus for the patients with hyperuricemia recommend the therapy in the patients with a high cardiovascular risk and inefficiency of medication treatment. One more question about uric acid. Can diabetes with metformin be a reason of increase of uric acid level? Yes. Hyperuricemia for a long time was a part of metabolic syndrome. There are certain metabolic ways, and in the diabetes, notwithstanding the metformin taken can be a reason for compensation, and it can lead. Now the question to Evgeny Sindrovich. The folic acid can it be prescribed at the same time as methotrexate? There are studies. At the moment, we have the standard therapies in 24 hours. Is there medical reaction between methotrexate and other anti-inflammatory drugs and contrast that are used for MSK? There is general potential of different therapies. They can be nephrotoxic, and methotrexate is also nephrotoxic. And what can you say about stem cells in rheumatoid arthritis? At the moment, lots of strategies for treatment of rheumatoid arthritis, and stem cells do not have evidence base, and I don't think it is really needed for us. Dear colleagues, you would not believe it, but 4 very good and wonderful presentations were on time, and we answered main questions. Thanks, Pavel, Roman, Evgeny, and all the colleagues who participated in our session, listened, asked questions. Thank you so much indeed. I think this was a very interesting session. Thank you so much and goodbye. See you later in Eurasian Association of Internal Medicine.